Hello and welcome to this webinar, the last webinar before our summer break. We have a very good friend of ours here at the studio, Elena Surkova. She spent some time actually in our lab some time ago, and she's had an incredible career coming from Russia. She spent some time with Luigi Badana in Pisa. Now she's at the Royal Brompton Hospital, and she's again back with us here in Vienna. So I'm really happy to have her. She's a real expert, and of course she's a terrific clinical doctor, and she's done a lot of research on some topics. So if you follow up on our speckle tracking lectures and courses that we're going to bring out soon, she's going to be part of it, and she's going to be part of many other projects as well. But now she's here at the webinar. Welcome for coming.
Thank you very much, Thomas. It's a great pleasure for me to be here and to join the webinar from this side of the screen. Thank you.
Yes, of course, she's a very faithful part of this whole project as well. Well, what is the plan for today? First of all, what we're going to do is I'm going to answer some of the questions that are coming in, because as you see, you have the option of even before the webinar starts to ask some questions, and I'm going to take my time we're going to take our time to answer these questions, and then we'll show you something that we're really excited about. It's a project we call Echo2Go, and we'll make a so-called live Echo2Go. Basically, it's going to be cases that we're going to show you where we will ask a question and you have the chance to answer them. So, but before we start again, let me answer some of the questions. There was a question that I do want to throw to Elena, where it was asked, what about the size of the left atrium? Could it be that someone has a small or a very large size and the patient does not have a pathology? Elena, how important is the left atrium?
It's quite important, and the correct sizing of left ventricle is a very important, of left atrium, is a very important issue, because it's prognostic marker, and there are a lot of publications showing its prognostic importance. And the question about the small left atrium can be very tricky, because talking about that, we have to be sure that we do measure left atrium volume correctly. I believe that the most common mistake for the left atrium volume quantification is LA foreshortening. We do need to use LA optimized images for correct quantification of the left atrium, and this could be the answer for this question.
Yeah, I think this is a very good question, because it's going to be one of the topics we're going to cover, and we have a case presented for you where Elena is actually going to talk just about this, so stay tuned, it'll come a little bit later. One question pertains to how do you image in difficult situations, especially getting an apical window if someone has a large breast. Well, this is obviously a problem. Well, I don't really see it as a problem, to be honest, because in reality the heart is not located where the breast really is. It's actually further cranial. So if you are underneath the breast, you will always get good images, and there is no evidence that the image quality you get in females is anywhere different than what you get in males. There's only one consideration where it might be difficult, and that is in breast implants. So that is something that I believe women should know beforehand, that they also have a limitation to imaging afterwards, right? Good, so I think we'll answer more questions. You have the possibility to ask them while we go along, also relating to the cases we have. I think we have a very short trailer now about the Echo2Go product. We'll show that to you so that you understand a little bit what the principle of this is. Okay, let's show the trailer.
You have many unanswered questions relating to echocardiography. Maybe you're a beginner, advanced, or maybe you're studying for an echo exam. Well, we have a product for you that I'm sure will help you. A learning approach we call Echo2Go. With this tool, you can learn anywhere at any time. We want to help you learn echocardiography, and we're more than delighted to be your mentor.
Well, I do hear that we have a little problem with the video. No matter, we're going to show it to you later. I also want to apologize for something which is really embarrassing. Of course, Luigi Badana is not from Pisa, but from Padua, of course. Anyway, they both start with P, and I guess at least I got the country correct. Anyway, let's move on to the cases, and let's start with this product that we call Master Your Skills Anywhere, Anytime, Echo2Go. It's a product that will be launched actually on Friday. So if you want to join in, it's going to be kind of a subscription-based product, you simply need to go to our webpage. We're going to revise that as well, and there you'll find the settings, the login where you can actually join this and see what it's all about. But of course, if you're in the webinar, you already know what it's all about. Good, so here is a case. It's the history of a 56-year-old male who was operated on an atrial septal defect 2 years ago. The patient actually came from the Ukraine, where he was also operated. But the problem was that he recovered very, very poorly, and the people did not really know what his problem was. He developed all sorts of obscure symptoms, and his hands were swelling, and he had dyspnea. And then he actually came to Austria, and we imaged him. And Elena, do you want to comment a little bit on the ventricle here? Of course, we're not going to give the answer away, but...
Yeah. Sure. So here we can see the four-chamber view, apical four-chamber view. We can find the left ventricle, right ventricle, and both atria. And probably you can note that the right heart chambers are clearly dilated.
Mm-hmm.
Just visual comparison between right and left side can give us an idea about dilatation of right heart.
Yes, absolutely correct. I think the quality is not good, but you can get a feeling. Definitely, we tried to look at the valves. The mitral valve and the aortic valve were okay, but Elena.
So, what do we see here? With the color Doppler, we can see a blue jet coming from the right ventricle towards the right atrium, and this is a tricuspid regurgitation. From my visual estimation, it's probably mild.
Yeah, I would think so too.
And this is the spectral Doppler, which shows us again the tricuspid regurgitation with the peak tricuspid regurgitation velocity around 2.5 meters per second.
So this is basically a normal pulmonary pressure. So that could probably not explain, or pulmonary hypertension cannot explain a symptom. So we did go on to perform a transesophageal study because we wanted to see what the problem really was. Especially, we did not have any reports, and we didn't really know exactly what the operation was that the patient had. But let's go, for all of you who are not so familiar with TE, let's explain the structures.
Sure, what we can see here, this large structure with relatively thick walls, this is the left ventricle, and this is the apex of the left ventricle. Here we can see the moving structure is mitral valve, this is posterior mitral valve leaflet and anterior mitral valve leaflet. Here we can see aorta, aortic root and aortic valve, and this is the small part of the right ventricle which we can visualize from this view.
Yeah, so it's basically a view which resembles the long axis view, and apical or peristern long axis view, you see basically the same structures. I would like you to, however, assess whether or not everything is okay here. We use color as well.
You can note here a very minor, very trivial aortic regurgitation, this minor blue jet coming from aorta to LB.
Yes, and the mitral valve was okay as well, even though the color is not placed there at this position. But let's now come to a view which is a little bit atypical. What you see here is in the central portion is the ascending aorta, so we're very much up on the base of the heart. And what you see here is the SVC. This is the superior vena cava. Now, of course, with this alone, you cannot decide what the problem is, but we'll come to that a little bit later. Now we're performing a contrast study. Remember, the patient had an atrial septal defect, so we are trying to figure out whether or not the patient has a defect or not. And this is the study. So what I would suggest you to do is look at it very, very closely, because there's very important information hidden in this contrast study. But just to explain the structures again.
So here we can see the part of the right atrium, the interatrial septum, and in the upper part of the screen we can see the left atrium.
Right. Just for your information, we can give you that much. This is a cranial, this is caudal. Here would be the IVC, here would be the SVC, and of course the contrast was injected via a venous approach. And now we withdrew the probe, we turn it around, we look at the descending aorta, and this is the descending aorta, and what we noted was that there was this rather large structure right here. We did inject contrast, again through a venous approach, and we saw that there's a contrast here. So based on these findings, here is our question. What is the problem of this patient after atrial septal repair? Is it everything is okay? B, the wrong pathology was corrected. C, the pathology was corrected wrong. Is there a patch defect there? Or the patient has a left to right shunt? So this is the question we would like you to answer. Basically, this is the format that we're using. So on the computer, of course, or on the mobile device, you can now click your answer, and then you get the answer video. And we're going to show you that in a second. But before we do so, I do want to answer a question again that is coming in from D. Cosme, who wants to know, where do you measure the thickness of a sigmoidal septum?
Well, that's quite important question because, of course, in sigmoidal septum, the thickness of interventricular septum is not equal throughout the structure. So my personal opinion is we have to measure the most thick part of the septum and to provide this value in the report, and probably to report where this the most thick part is located.
Yeah, that's exactly the way what I would do it too. You know, you describe the anatomy, you say, that's how a report could look. There's a sigmoidal septum with a basal septal bulge which measures 14, 16, 18 millimeters. The residual septum, however, is only 12 millimeters. So that way you can kind of get a good appreciation of the true thickness of the wall. And of course, if you want to really perform even more exact measurements, you would perform mass measurements of the LVS. Good. So I think it's time that we turn to the answer. So the correct answer is C. The pathology was corrected wrong. Well, unfortunately, this patient was not correctly operated. And to explain you what actually is the problem, I want to start out first with his primary pathology. He had a sinus venosus defect. This is a type of atrial septal defect which is usually located very cranial in the interatrial septum, exactly in the region where the SVC enters the right atrium. These patients very frequently have associated with it an anomalous pulmonary venous connection, in the sense that usually a right pulmonary vein drains into the left atrium. This is a patient, not the same patient, that demonstrates here what the pathology is all about. This is the interatrial septum you see here. This is the left atrium, the right atrium, and we're injecting contrast through the SVC. You see it enters here. And then we see that there's a communication here with a washout. That's why contrast in this case is not entering the left atrium. But this is a defect here. You see, that is the problem. And obviously, when you operate these patients, you want to operate everything. You want to close this defect, and you want to redirect the anomalous pulmonary venous connection back into the left atrium. So that's the idea behind it. And what happened in this patient, and I can just show you slowly, is that he seems to still have some form of volume overload of the right heart, because, as Elena noted in the question, the right atrium is quite enlarged. Now, when you take a look at these images here, you will first of all not see a residual defect here in this region, but what you do see is that you have this flow, this prominent flow here coming into the left atrium. Now, this could be a normal connection of the pulmonary vein, of course, but when you enter contrast, all of a sudden you see that actually there's contrast coming from the right to the left. So this was not really corrected. And even worse, when you look at the flow of contrast, you will realize that actually the first place the contrast enters is from the IVC. It's not coming from the SVC. And no matter what we did, if you used color Doppler, if you used contrast, we were not able to see flow coming from the SVC into the right atrium. It was just closed. So the problem here was that this patient had the ASD closed incorrectly, in the sense that they just shut off the SVC, and that there is still a connection between the SVC, probably via the pulmonary vein, into the left atrium. And that in addition to that, as you will see later, there was also a problem with a connection to the pulmonary artery. Now, what you see here in this short axis view is, this is the atzicus vein. because as we saw in the contrast was coming from the IVC. In other words, there must be a connection between the SVC and the IVC, and that is via the atzicus vein, which is massively dilated and fills the IVC. This is a contrast study now in angiography that definitely shows you that there is a stop of contrast right here. This is the SVC, we're injecting contrast here, and then this is the huge atzicus vein, which is going all the way down here. And here is the connection between probably the pulmonary, the SVC and the pulmonary circulation, arterial circulation. So, of course, we have to analyze in detail how these vessels were redirected, but it definitely explains the problem of the patient, and we'll have to look into, of course, treating these patients. Elena, let me ask you a question. Do you see many patients with atrial septal defects?
Not so many, and the main point is that if we are talking about sinus venosus defect, I believe that it diagnosis which can be easily missed if we use only transthoracic echocardiogram. What do you think?
Yes, this is exactly one of the most important issues to be aware of. It's quite simple to detect an ASD2, so, not always, but in many cases, but it's very, very difficult, if almost not impossible, to really detect a sinus venosus defect. So, you know, there's certain situations, clinical situations, where you have to be aware that this could be a problem, as in this case, a large right heart. If you have a lot of flow across the pulmonary artery, especially if you compare it to the systemic flow, and of course, if you perform a contrast study and it pacifies, then this would always be an indicator. Maybe on a last note, the issue of contrast is a very, very important one. There's so many uses of contrast to not only look at the classic things like shunts, but it's also important to identify structures frequently. And I think when we come back to this transesophageal study where you saw this short axis view, we were able to actually identify what kind of a vessel this was. So I think that clearly shows the advantages of combining many modalities.
Yeah, that's true. A very clear case and showing the importance of multimodality approach.
Yes, yeah. Good. Now let's turn to some questions again. Prashant asks if a patient has severe concentric hypertrophy and is a known case of hypertension, so we can name this patient as hypertrophic cardiomyopathy or hypertensive heart disease. Good question. Elena.
Tricky one, I would say, because obviously, in some cases, severe hypertension and hypertrophic cardiomyopathy can look very similar on the echocardiography. What can help us to distinguish between these two pathologies, whether hypertrophy is symmetrical or not? Normally, for patients with hypertension, left ventricular hypertrophy should be symmetrical. If we have asymmetrical cases, for example, isolated thickening of intraventricular septum or apical hypertrophy, we should suspect different pathology, we should suspect cardiomyopathy. Also, strain can be helpful in the differential diagnosis. Do you agree?
Yeah, absolutely. The strain is such an important modality. If you have classic hypertrophic cardiomyopathy, you would usually see a reduction in strain, especially in these areas where the fibrosis is most prominent, and that can be very patchy. Usually it's in those areas where hypertrophy is most. So I just completely agree with what Elena is saying, and I think it's also important to understand these definitions. Hypertrophic cardiomyopathy is actually a genetic disease that causes hypertrophy, and these patients do not necessarily or usually do not have hypertension. While hypertensive heart disease, there you would have hypertrophy really due to this pressure overload. And yes, if you use the blood pressure, you can differentiate the two, but not always, as Elena mentioned. Good, I think we can move to the next case. This is a patient that I guess you will probably relatively quickly identify what the problem is, but this is not going to be the question. But Elena, do you want to comment on this here?
Of course, again, we can see apical four-chamber view, LV-focused apical four-chamber view. We can see the central structure with the left ventricle, and we can see this moving two structures, which are leaflets of mitral valve. And probably, again, as Thomas pointed out, that you can already spot a pathology here. Look at the motion of mitral valve leaflets. Look at the coaptation of the leaflets.
Right, this is when you already see a coaptation defect on the echo of the mitral valve, you probably do not have to use color Doppler to not only know that mitral regurgitation is present, but that it must be severe. But we'll also come to the mechanism of this this pathology, but I want to maybe just show you some additional images before we do this.
So this is a 3-chamber view, long axis of the left ventricle, and again we can see posterior mitral valve leaflet on the left part of the screen, anterior mitral valve leaflet. Also we can see aorta and aortic valve close to the mitral valve, and the part of the left atrium.
Yes, and I think the striking finding here is that there seems to be some mitral annular calcification, again this coaptation defect, and maybe already start focusing on left ventricle function, because this is going to be part of the question. Next view we'd like to show you is this one here, and I guess now we're confirmed.
Obviously there is severe massive mitral regurgitation, and just again pay attention at the calcification, these bright white parts in the mitral valve annulus.
Mm-hmm. Would you use PISA here?
2D PISA is not an ideal method for quantification of mitral regurgitation, of course. Here, to be honest, it's obvious that it's severe.
Yeah.
We can try use PISA. However, if the orifice area is not round, is not circular, it's quite complicated.
Well, I'm not a big PISA believer either. It has many limitations, and in essence, I think I agree. We'd really love to have an exact measurement of volumes, because there is much more information opposed to just quantifying mild, moderate, or severe. But I think in this case, we actually did perform the PISA, and we got a regurgitant volume. I do not know if it's correct, but it was 120 milliliters. Okay, now what is the normal stroke volume? Well, that's somewhere in that range. So basically what we're saying here is that the entire stroke volume was actually going in the wrong direction. So that is, it would be a massive MR. I would probably think it's a little bit less, but it just exemplifies the severity of mitral regurgitation.
And again, it means that the left ventricle should contract more powerful, because it needs to produce larger stroke volume, part of which goes back to the left atrium.
And that's exactly why you would actually be expecting hyperdynamic function. Here's the 4-chamber view. You see pretty much the same finding. You see that there's a huge flow conversion zone. I mean, the entire atrium is filled out with this regurgitant jet. But we obviously looked at the tricuspid valve again also, and Elena.
It's massive tricuspid regurgitation again. You can see the very flat, very elongated PISA. Mm-hmm. Actually, and also you can see in spectral Doppler the peak velocity around 4 meters per second. And also we should note very dense signal in spectral Doppler, suggesting the severe tricuspid regurgitation.
Yes, so this is probably a secondary problem related to this mitral regurgitation. Patients develop pulmonary hypertension. Right ventricle function is starting to deteriorate in this patient. That's why the ring is getting larger. That's why you have tricuspid regurgitation. And the pulmonary hypertension is certainly also related to his symptoms. So the patient was also in almost pulmonary edema. And this is not an image where we did not know where the heart is, but we were actually imaging the lung. And what you so nicely see is these classic B lines here. Those are these artifact rays, which have an important diagnostic importance. Why?
Because they can be signs of lung congestion.
Yes, it's a really neat way of looking at it. You might not even know need the stethoscope if you want to look at that as well. So, of course, you would still use your stethoscope, but the finding here is just to confirm that the patient was in pulmonary congestion. But now we'll come to the question, and it's just a question where we'd like to have your opinion. Of course, you cannot know, but what do you think? How do you think longitudinal function is in this patient if we perform a speckle tracking analysis? Do you think it'd be very high? Remember, the ventricle has to be hyperdynamic, so the cutoff values are somewhere in the 18-19% range. Do you think it's going to be above 25? Will it be normal? Above 18? Will it be markedly reduced? somewhere below 18, maybe 17 or 16? Will it have a special pattern where it will be poor at the apex and otherwise normal, or will it show the pattern of an anterior myocardial infarction? So this is the question we'd like you to answer.
And while you are thinking about the answer, try to think about the pathophysiological consequences of mitral regurgitation. What is going with the volume of the left ventricle, with the volume of the left atrium? What is happening inside the heart? Try to think and understand it.
I think this is just so important that you understand the hemodynamics of this and the severity of the problem. And as you will then see with the answer, we'll allude on this a little bit more in more detail. Let me answer some questions. There's a question about continuous wave Doppler in cardiac ultrasound and how that can be influenced by noise. Yes, you do get a lot of artifacts, not only in 2D, but also with continuous wave Doppler. We have, of course, reverberation type artifacts there as well. You can sometimes have harmonic waves within this continuous wave Doppler. So yes, there are many things that you have to understand. Doppler 2 underlies the classic physical principles, so you can have artifacts there as well. Then Lee wants to know, I'll just translate into English, when will we finally have our speckle tracking course online? Well, as a matter of fact, we are sending out another case of this in the next few days. The status of this is that we are changed a little bit our strategy in the sense that we are now incorporating even more experts. We've got Elena here, that's why she's here. We had Ole Breithardt here. We're going to have some really big hotshots. And we, of course, think that this will greatly expand the quality of this course. And we think that we need this. And therefore we did, I must apologize, postpone the launch date a little bit. And we will launch it, however, in the fall. So you have to wait a little bit until summer. But as a little excuse from us, what we are going to do is we're sending you just continuous tidbits already so that you have something to watch and that so you see something. In essence, I think the main goal of us is to produce a course where we incorporate not only my opinion, but the opinion of really all of the global leaders who work on this field. And therefore, I must apologize, it will take a little bit longer, but we are definitely on course, and we've got some really great material already. And so stay tuned, and I'm sure that you will like the course and it'll be a great educational product. Good. So I think it's time that we now move to the answer. So the correct answer is it will be markedly reduced. How can we see and how can we know that it will be reduced? Well, let me show you the speckle tracking echo case first. And maybe, Elena, can you comment on this and maybe explain what speckle tracking is in very brief terms for those who have not been using it so far?
So speckle tracking is a tool how we can measure the deformation of myocardium, actually the shortening of myocardium during systole. And here we can see the bull-eye view, so we can find 17 segments of the left ventricle analyzed separately and the color coded in a specific way. So the red color shows actually normal contraction, normal speckle tracking values. The light red, almost white, are decreased, and when we see the blue, it means that during systole, actually these segments are not shortening but lengthening. So from here we can appreciate that the contraction, the shortening of the apical part is okay, so it's preserved. However, all basal segments have reduced longitudinal strain.
Matter of fact, this is the typical pattern you see in specific diseases, but actually I would say it's a universal phenomenon that when strain starts to get worse, it usually starts to get worse at the base and then progresses more and more towards the apex. So in this individual patient, the longitudinal strain was somewhere in the range of minus 16%, which is below the normal value. In principle, if you remember the case, this patient has massive mitral regurgitation. So, and as Elena pointed out, these patients should have very hyperdynamic function so that we would actually expect higher than normal values for strain. So I think the real value of this is that we have another way of looking at left ventricle function, which might be, especially in such a setting, more objective than just looking at ejection fraction. Let me maybe go back to some of these images again, and maybe we can just talk about this case and also about the mechanism why this patient has mitral regurgitation in the first place.
That's a good question. If you can look at the mitral valve leaflets, especially at the motion pattern of posterior mitral valve leaflet, you can see that it moves really slowly with very small distance. And you can see the very bright, large, white structure at the base of the posterior mitral valve leaflet. So we believe that this is a calcification of posterior part of mitral valve annulus, which restricts the motion of posterior mitral valve leaflet.
Yeah, I think this is an under-recognized mechanism of mitral regurgitation, and it doesn't always have to do with the magnitude of calcification, but more with the location, I believe. I mean, from my understanding, what happens is that if you have the calcification here and if you have the mitral leaflet here, this calcification grows and the leaflet underneath gets more or less more and more restricted, and in a way it cannot reach up all the way anymore to the mitral valve. And then once the motion is restricted and is pulled away, then you have a coaptation defect, and I'm certain that you have an additional factor here, annual dilatation as well, which comes into play. But I think that the structure or the way we have to assess the mechanism of mitral regurgitation, I think must be even more refined, because we do find more and more factors which influence the degree of restriction or regurgitation. Now let's take a look at this here, and I think...
And again, we can spot very prominent calcification of mitral valve, of mitral annulus.
Yeah. And with respect to the mitral regurgitation, we talked about that already. I guess it's quite clear. We said that PISA is something you can use, but we don't believe too much in it. How would you quantify mitral regurgitation now, specifically in this case? What would be the criteria why you think it's severe?
Well, we can firstly visually assess the mitral regurgitant jet. And clearly we see the quite wide vena contracta. We can see the area of the jet, which is filling the whole left atrium. We can use PISA and vena contracta measurements. For that, we have to reduce this, the baseline of the color, and we have to trace to measure the diameter of the PISA and to trace the spectral Doppler signal for mitral regurgitation. However, from visual perspective, it's quite significant.
Yeah, I think that all the criteria are there. Now, I think in conclusion, what we can say from this case, and that's something that is just a thought that I would like to bring forward to you. You know, when we look at the cutoff values for surgery, now in this case, surgery is obviously indicated because the patient is symptomatic. But if we look at the cutoff values, we always have the issue of left ventricular function included. And we say, because we know patients with MR have hyperdynamic function, we have a higher cutoff value. But what we do not really understand is that this cutoff value is so fixed, and there might be patients who have so severe mitral regurgitation that you would not expect an ejection fraction of 65, but maybe even 70 or 80. And anything that below there is maybe already reduced. So I think that we are desperately in the need of using additional techniques of assessing ventricular function and relating the degree of regurgitation with the function of the heart. And that's why I believe that speckle tracking really has a very important role here.
And we also have to remember that already in current guidelines, the cutoff value for normal versus abnormal left ventricular ejection fraction in patients with severe mitral regurgitation is 60%.
Yes. Exactly.
Not 52, 54 as for normal left ventricles.
That's completely correct. Good. So let's now turn to another patient. This is the next case we'd like to show you. Also, actually a very tragic case. It was a relatively young individual who had a thymoma, and he had a metastasis in the heart, in the apical region. And we discussed long and broad what should be done, and you know, I was not involved in this, but the surgeon definitely decided that they should operate the patient. And they said that they need some kind of support of the ventricle because they're taking part of the myocardium out, so it's probably better if you also implant a patch there. And that's what was actually done. And this is now the echo I'm showing you. This is the first time I saw the patient. And this is the image now focused towards the apex of the left ventricle. Elena, do you want to maybe explain the structures or how this is actually imaged? And
yeah, so it's slightly not standard view, let's say. Here we can see the apex of left ventricle. This is the cavity of left ventricle and mitral valve. And we can see also this structure here. Can you comment on that? What is that?
Well, I remember we had a patch in place, and I would assume that this is the patch which is seen right here. I mean, this was not the structure that really was of concern to me. I was wondering what is going on here, and what do you do if you want to see more of the apex? What would you suggest?
Well, normally I would use contrast.
Okay, so that's exactly what we did. So here is now the contrast study. Here are several different, slightly differently angulated views and phases, and I want you to take a look very closely at these images. We're not seeing the septum here, but we're focusing on the apicolateral region right here, 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 and here. Just a few words while you look at these images about the contrast in general. We're using a left-sided contrast agent, which allows us to pacify the left ventricle. And it is a very nice way of distinguishing, for example, normal structures from a thrombus to delineate the endocardial cavity. But now that you've seen these images, so do you want to make another comment on contrast?
Yes, just explain some simple things. The blood, actually we can see the blood as a white color, and the walls of the myocardial are black here, gray, let's say.
Yeah, I think that's very important.
Yeah, and the specific finding in this patient is this. Okay.
And I wanted to give it away, but of course she gave a little hint. Maybe you can pick up the hint and answer the question. So we'll come to the question. The question is, what do you suspect in this patient? Is it A, nothing? Everything is okay. This is a normal contrast study 3 months after tumor extraction in the apex. Is this a reoccurrence of the tumor? Did you see a mass there? Is there a thrombus? Does the patient have a pseudoaneurysm of the apex, or do you think the patient had a myocardial infarction? There was actually a wall motion abnormality here. So make your choice. Good. I think we will now move on to the answer. Elena, what is the answer?
Well, the answer is obvious, recurrence of the tumor.
I think it's, of course, something that this was the reason we actually performed the follow-up study. We wanted to know if the tumor had grown again, and it's very difficult to really see with a transthoracic echo without contrast. So that's why we added the contrast. And what we also performed is an MRI image, and what you can see here is this patch that was performed. And then if you look here in the apical region, there's definitely a mass again. So this is the metastasis of the thymoma again. So clearly a tumor is present. But what I do want to show you is I want to show you that in reality, we were also able to see this with echocardiography. So if you go back to these contrast echo studies, you saw that the cavity, of course, opacifies very nicely, but that there's an echo lucent area right here. And that if you look at the contrast, the flow of contrast, you will realize that there's also some flow into this region. So it's a perfused region, which is typical for tumors. So compare this with this, and I believe that you can get pretty much the same information. So MRI is not so, echocardiography is not so bad after all,
exactly.
Right?
Completely agree. I'm a big fan of echocardiography, so very supportive of this point.
Yes, I think that MRI still has its place. Do you use it quite frequently, or what are some of the indications in the setting of masses and tumors?
Well, CMR, cardiac MRI, is a very useful tool in many ways. And the main advantage of this technique, to my mind, in comparison with echo, is its ability for tissue characterization. Mm-hmm. Echo is not able to do that, and with CMR we have a lot of opportunities to characterize the tissue in the heart.
I mean, definitely MRI has its advantages, and it's a really nice technique to create extremely good image quality. You see, look at the patch here, how nicely you can see this. So it has its edge, but don't forget that we can do many things with echocardiography, and that I've seen spectacular images that in my view actually look better than MRI images. The only difference really is if you cannot really see the surrounding of the heart as good with echo opposed to MRI, and the frame rate obviously is much higher with echocardiography than with MRI. But in this case, it just highlights again the importance of echocardiography in using contrast and shows what we can do with this technique. Just to follow up what happened to the patient, well, he was reoperated once more. This time they excised more of the myocardium, but now the patient has a rather large aneurysm at the apex. We'll just have to see if he was lucky now and if he was treated with his thymoma. Good, so this was the third case we're showing you. Now I want to kind of hand it over a little bit to Elena, because I mentioned right at the beginning of the webinar we're going to talk about the left atrium, and I think this is her case. Please.
Thank you, Thomas. So let me start my case presentation from this very simple video. You can see 4-chamber view and 2-chamber view. And my question is, how do you think large is the left atrium? Just from these images, what do you think? Is the left atrium very small, normal, moderately dilated, severely dilated, or you cannot tell just based on these images?
So, but this is of course it's not the question that you will have to answer later on. We have another question for you, and the question here is,
okay, how shall we assess the size of the left atrium in this case? There are several options. Shall we measure anteroposterior diameter of the left atrium? Shall we quantify maximal volume by 2D echocardiographic techniques, for example by biplane method of disc, biplane area length method? Shall we use single plane method, or shall we use 3D echocardiographic analysis for the left atrial volume?
Okay, so make your choice.
Think about how large this atrium is and how would you quantify the size of this atrium. And we can move further,
Yes, I think
believe.
we can talk about the answer.
Yeah. And so the correct answer is, in this case, I would definitely go for 3D echocardiographic analysis. From these images which you saw, probably it's a bit complicated to say why this answer is correct, but I will explain in the next slides. So here you can see again 4-chamber view, 2-chamber view of the left atrium of the heart, and then we acquired 3-chamber view. And you can see that the shape and the size of the left atrium in 3-chamber view is completely different from the 2 views which we saw before. So it's very long, elongated. It's, I would say, slightly compressed by the structure close to the left atrium, which is aorta, aortic root. And you can see that actually from 4-chamber view, what we see in 4-chamber view, it's definitely foreshortened view of the left atrium. So it's quite complicated to get correct numbers of LA volume in this patient using just standard 4-chamber and 2-chamber views. Just to give you some more details about how to obtain correct views for the left atrium quantification, we can look at these structures, at these figures, and we can appreciate that the long axis of the left atrium and the long axis of the left ventricle are in completely different planes. For example, here you can see that in order to obtain the true length, the true area of the left atrium.
Oops.
Yeah. So in order to obtain the true area of the left atrium in 4-chamber view, that's how much we should foreshorten the left ventricle. And it's completely impossible to do just with 2D echocardiography because we do not have anatomical landmarks for that. What we can see from the normal standard 4-chamber view is actually this small part of the left atrium, which we can see here. So we see the full left ventricle length and very small part of the left atrium.
I think this is an extremely important teaching point, because what I frequently see as being done is that one acquires a 4-chamber view, a loop, and then they do all the calculations from this one loop. They look at the ventricles, they look at the atria, when in reality you should optimize it and probably image separately the atria, optimize, and at the same time also optimize for the ventricles. So I think this is a very important reason.
Exactly, because this view is completely optimized for the left ventricle, but not for the left atrium.
But why is the atrium, why does it have such a strange shape?
Well, let's go into details about that. So, the answer for this question is the shape and the size of the aortic root. This patient had dilated aortic root. The measurements at the level of sinus of Valsalva was 40 millimeters. And you can see again in 3-chamber that aorta compresses the left atrium, compresses the mitral valve annulus, creates the small degree mild mitral regurgitation, and so affects the normal shape of the left atrium.
I think maybe just as a comment here, this is something you do see that heart structures influence each other. For example, you will have situations where the left atrium is very large and it also pulls on the right atrium, so the right atrium is often also extended. And this must be considered, and you can have all sorts of bizarre shapes of the atria, as for example in this case here.
So, but we still need to quantify the size of the left atrium. And let us try to understand what the guidelines says. So there are two main methods for 2D volumetric analysis of the left atrium. It's a biplane method of discs and biplane area length method. And current guidelines say that biplane disc summation technique method of discs, it theoretically incorporates fewer geometric assumptions, and it should be preferred method for measurements of LA volume in clinical practice. And here you can see the reference values and the CVT cutoff values for left atrial enlargement. So we have to consider all the patients with LA 2D volume less than 34 milliliters per meter square as normal left atrium.
But I think the societies, at least in these newest guidelines, did change the recommendation of the categories. Do you want to comment on that a little bit and why this was done?
Yes, exactly. If you remember, in previous version of cardiac chamber quantification guidelines, the cutoff values for differentiation between normal and abnormal left atrium was completely different. It was 28 milliliters. I believe some of that range. And now they increase significantly. However, the reason why it happened, well, there are several reasons. First of all, the new guidelines relied on the new studies in large groups of healthy volunteers and in large group of patients. And in these studies, it was shown that the left atrial volume, more than 34 milliliters per meters per square, has important prognostic implication. So it's important prognostic markers of cardiovascular events and survival in patients with different cardiovascular diseases.
I completely agree, but my suggestion here is that you take these values and post them somewhere up in your lab. You can also use, of course, our app. We have the normal values there as well, but it's important to know this and to grade it because if you put these values alone in your report, then someone reads them, they have no clue where the cutoff values are because nobody can remember all these numbers.
So, we do not need to use the method of disc, for example. We can use area length method, but can we use it in every patient? Are they suitable for everyone? My answer, no. And we need to remember about its limitations and about potential sources of errors in LA volume quantification. And the first one and the most important one is LA foreshortening. Obviously, if we use foreshortened windows, foreshortened views for left atrium, we will come up with slower volumes. And it's critically important to obtain LA-focused views for quantification of left atrial volume. The second point, the length, the difference of the length in 4-chamber and 2-chamber view of the left atrium is important. Just be honest with yourself and try to answer the question, how often do you check the length of the left atrium in 4-chamber and 2-chamber view? Have you ever done it in general? However, from the guidelines, it's clearly stated that we cannot use these methods, neither of them, if the differences in length of the left atrium more than 5 millimeters.
As a matter of fact, the same is true for the ventricle as well.
Exactly.
You have to have similar lengths in the 4 and the 2 chamber view, otherwise you can just dump the Simpson calculations. Maybe just for those who are not so familiar with areal length and method of disc methods, basically what you have in many scanners is you have either the option to set how should the volumes be calculated, or they sometimes give you both values and then you kind of don't know which one are you supposed to take. So which one do you take?
Well, normally we take method of disc as it recommended as a preferred method in current guidelines. However, there are several papers showing that areal length method gives a better correlation with CMR, with LA volumes measured by CMR or cardiac CT. Okay. So this question is still unclear which method we should use.
But you mentioned before that you would use a completely different method.
Yes, but first let me finish with the limitations and explain why I need to use a different method in this particular patient. So we have to remember that both these methods rely on geometric assumptions about left atrial shape. Both these methods assume that left atrial has an oval shape in cross-sectional plane. And you may imagine that in these patients it's not true. And another option which we have to remember is the fact that there is a systemic bias between the LA volumes produced by areal length method and method of disc. So normally the difference, normally the areal length method gives you larger volumes than method of discs obtained from the same tracing of the endocardium of the left atrium. And this is important, especially in patients' follow-up, because we have to know and we have to measure left atrium with the same methodology as before. And the most important thing, that the difference is larger in patients with regular shape. So if you have the patient with abnormal shape, which is far from being oval, you have to be careful with the method you used for 2D quantification.
Important teaching point here.
Yeah. What have we done? So we tried to optimize our views to get LA focused view. We were not able to improve much the 2-chamber view. However, we managed to improve somehow the 4-chamber view. So we created this LA focused 4-chamber view. Unfortunately, we were not able to remove aorta from the screen because dilated aortic root always appeared in the screen. However, we got more or less larger area of the left atrium. And then we did tracing and we got our results. And we got completely normal values. So the volume of this left atrium was 23-24 milliliters per meters per square. Then we compared the length of the left atrium in these two views, and the difference was exactly 5 millimeters. So we still can use these methods, but we are really on the edge. This is an important point. Another important point why we have some doubts about the methodology we use in this case is the shape of the left atrium. So, as I pointed out before, we moved to 3D echocardiography, and here you can see 3D reconstruction of cardiac structures. You can see aorta, aortic valve inside, and here you can see the mitral valve annulus, and you see how much it's different from being oval. It has crescent shape, so completely different from elliptic one. If we move lower towards the aortic root, we can appreciate the shape of left atrium in cross-sectional plane. And again, it's very far from being oval. And that means that by definition, the methods which we used will provide us the wrong numbers. So that's why in this patient we used 3D volumetric analysis for quantification of LA size. We performed tracing, and here you can see the final results. And the LA maximal volume, which we got, was 53 milliliters, which in comparison with 35 with 2D.
Pretty big difference, isn't it?
Exactly, exactly. So this is the case where the 3D echocardiography gives you an advantage.
Right. Yeah. Let me just kick in here and ask a question. I mean, this is obviously theoretically completely correct, but how should we do this in practice? We cannot really perform 3D in every patient. You know, does it really make sense to get these detailed informations? How far would you go with assessing the size of the left atrium?
As I said, the correct assessment of the size of left atrium is very important because it's a important prognostic marker. Especially it's important in follow-up of the patients after some intervention procedures, for example. And it's also important because it's one of 4 key points in diagnosis of diastolic dysfunction. So precise, accurate assessment of LA is crucially important. I agree that probably we do not need to use 3D echo in every single patient. But in some patients groups, such this patient with a regular shape of the left atrium, or for example, when we cannot avoid foreshortening of LA in standard use, we have to use 3D or other imaging modality. And let me move to the take-home messages of this presentation. So, left atrial enlargement is an independent predictor of adverse cardiovascular events in many cardiovascular conditions. Currently, biplane method of disc is a recommended one for routine assessment of LA size in clinical practice. However, we should always remember its limitations. First of all, it relies on geometrical assumptions on LA shape. If the shape of our left atrium is different from oval, we cannot accurately quantify the volume with this method. Secondly, we should always pay attention to the difference in LA length. And if the difference is more than 5 millimeters, it means that at least in one view, you significantly foreshorten the left atrium and you cannot use it. Additionally, yes, we have to try and avoid LA foreshortening, and we have to use dedicated views for left atrial volume quantification. We have to remember that method of discs provides smaller volumes than area length method. And we have to use the same methodology in follow-up patients. And ideally, we have to record the method which we used for quantification of left atrium before. And my final point, that we have to use 3D echocardiography or other imaging modalities in patients with abnormal left atrial shape.
Elena, fantastic. Thank you very much. Well, we're coming close to the end of the webinar. We would actually have a wonderful case that Elena prepared actually for the St. Wolfgang meeting and won a prize for. Of course, we're running a little bit late, but to be honest, I do want to show you this case as well. So if you feel like you have enough of us or you need a break, take a break. You can always watch the video online. You have our webpage with the webinars. You can look at it offline as well if you're kind of tired. But I think I do want to give Elena this chance, and also I want to see this case again. Elena,
thank you very much. I will try to be fast. And let me start this case from a very simple question. What is the mechanism of mitral regurgitation in this patient? Obviously, from these views, you can see that mitral regurgitation is definitely more than mild. It's quite impressive. You can see the motion and the structure of mitral valve leaflets. Again, you can appreciate the mitral valve jet. Just try to think and understand what is wrong here. What is the mechanism for mitral regurgitation? So what do you think? Is it organic? Is it functional? Ischemic, probably? Just try to understand the mechanism. And meanwhile, I will give you some more clinical information, clinical details about this patient. So the whole story began in the province of Lower Austria several years ago.
This is Mistelbach. This is a very small town. I think that's why the image is there.
Yeah. So we had a 46-year-old lady. She admitted to the hospital with cardiogenic shock and pulmonary edema. She had been feeling low for a few weeks before admission, and she had no significant previous medical history. Well, from these images you can easily spot the pathology. You can see the huge mass occupying almost the whole left atrium, protruding through mitral valve, and creating some sort of mitral valve stenosis. Here with this color Doppler, you can see that there is literally no room for blood in the left atrium. Definitely it creates the secondary mitral valve stenosis, which can explain the pulmonary edema, but it also creates the low cardiac output and can explain the cardiogenic shock. So, the pathology is clear, the answer for symptoms is clear, but what is the structure of the mass? What is the diagnosis? Is it myxoma, or probably it is a thrombus, or the worst thing, malignancy? Let us look at some other images and try to get some other clues from echocardiography. So, we performed transesophageal echo, and here you can easily spot that there are actually not one but two structures in the left atrium, and this is not a good sign. Also, you can understand that these structures are pretty inhomogeneous. There are some areas of different color, of different structures inside. It can be typical for myxoma. However, it's, well, pretty unusual sign. Can it be a thrombus? I'm not too sure about that.
Well, I think Elena just mentioned some of these things, and I think this is so important that this case beautifully highlights how you differentiate these different forms. And the homogeneity is one issue. You will have a little bit of inhomogeneity also in myxomas, if you have necrosis in the tumor, for example, also in a thrombus, but it's never to that extent. And you know, you get this feeling, and I always have the impression that this just cannot be, you know, a benign tumor. And then I think, as Elena mentioned, it's two parts. But maybe you can go on and show some other features of the tumor.
Yes, exactly. So here you can see that at least one of these two structures is attached to the interarterial septum, and one can believe that this is a typical sign of myxoma. However, I would not agree, because myxomas normally have very small stalk, and here this mass has very large, very broad insertion. And again, this is not a very good sign. The next images, you can appreciate that there is some thought of some degree of pericardial effusion here, which again, quite not a very good sign. And the last one, there is a clear invasion of interarterial wall. You can easily spot the part of the tumor attached to the interarterial wall, and you cannot delineate it from the wall. So it's a clear sign of invasion. To summarize, several masses, invasion of left atrial wall, pericardial effusion, and the truth is out. We performed the surgery, surgical removal of the mass, and biopsy confirmed our thoughts. It was a rhabdomyosarcoma, myosarcoma of the heart, which is a highly malignant tumor. After surgery, the symptoms of this patient improved remarkably. So she recovered very fast, and here we can appreciate trivial mitral regurgitation, normal function of all heart chambers. However, unfortunately, it's not the happy end of the story. 1 year later, we can see the images of the same patients, and they're completely different. You can appreciate the significant degree of mitral regurgitation. You can also appreciate the thickened mitral valve leaflets, and yes, very clear structure on the posterior wall of the left atrium, close to posterior mitral valve leaflet. So unfortunately, this patient has metastasis and recurrence of the tumor in the left atrium, which causes some degree of mitral regurgitation.
I think that's just a very important point, because remember, Elena started out showing you about the mechanism of mitral regurgitation, and we always tend to say, is it functional, is it structural? I think that, you know, we are not aware of that. Can be so many problems. In this case, it was this mass which was also invading the mitral valve and causing incompetence there.
Just to summarize, what do we know about primary rhabdomyosarcoma of the heart? So it accounts for 5 to 20% of all cardiac malignant tumors. This is the second most common primary malignancy of the heart. It can be found in any chamber. It can be single or multiple, and grows invasively. It can also infiltrate the cardiac valves, and it has high rate of metastasis and recurrence, and unfortunately the mean survival of these patients is very poor. My take-home messages are that primary cardiac tumors are rare, but they are an important cause of heart failure symptoms, and they should not be overlooked. The prognosis of this patient is poor as a result of local recurrence and metastasis. And the malignant infiltration of the valve and atrial wall may lead to severe mitral regurgitation, which we observed in this patient. Thank you very much.
Well, unfortunately, the patient did die 2 years later, but you must imagine that, as Elena mentioned, they usually have a very, very poor prognosis of only 5 months. In this case, operations, we performed 2 operations. The patient actually at least prolonged her life, and she had a relatively good, I would say, quality of life for an extended time that she still survived. So I think that again highlights some of the importances of sometimes using echocardiography in conjunction with other imaging modalities to decide what we can do. Okay, I think we're running late. I think we should close it here. I want to just take the chance to answer one more question, which is not really an echocardiography question. It's from Enel Maha. She wants to know, how can we diagnose fatty liver? Of course, I'm not a expert in this area, but as far as I know, and I hope this will help you, you look at the echogenicity of the liver, you compare it with that of the kidney, and you usually have a very hazy appearance of the liver, which is relatively bright. I do look at that because when we perform subcostal views, we do see pathologies of the liver as well, and I would always encourage people to look outside the heart as well, because sometimes you can't find findings which have been not seen previously or might even relate to the heart. Good. That being said, again, I want to thank all of you who are with us and stayed so long that you, of course, saw all our cases. And I want to thank, of course, once again, our entire team for putting this up. I think they did an incredible job again. The complexity of this might not always be clear to you out there, but we're very happy to have them. And of course, I want to really, really thank Elena for being here with us. And I think we'll go for dinner now. Take care.
Thank you.
And see you next summer. No, next year.